You can share the screen, sir.
Yeah, I will start sharing my screen.
Thank you.
Are you all able to see the screen?
Yeah. Yes, sir.
Yeah, so the task given to me was to talk about chronic kidney disease, 2 decades of progress and challenges for the future. And as mentioned by Professor Gupta, that ERA-EDTA is a very important meeting, and a lot of the plenary sessions done over there are of immense interest to all of us in our country. And this year's plenary session was given by Dr. Andrew Levy, who was the former chief of nephrology at Tufts University of Medicine, Boston. And as you all know, that he has, on his 20 years of his career, has put in immense work to bring creatinine and proteinuria to these important markers of kidney disease to be used into the clinic and how best we can use the clinic. So what I have done, originally what was planned was Dr. Rajapurkar was supposed to do the talk, but unfortunately he can't be here today. So I am substituting for Dr. Rajapurkar. And the plan was that he was to give the highlights of his talk, which of course was about 40-45 minutes. But what I will do in 10 minutes is to give the highlights of his talk and then take up some things which are important to us in our country, and maybe during the panel discussion and other things, more things can be discussed about it. So Dr. Levy began his talk with acknowledging the contributions made by the faculty at the Tufts University, who were important for all his journey, and he also important acknowledgements about his family. And just to tell you something about his personal thing, he has also been a kidney donor, and through a kidney exchange program for his wife, who is a patient of ADPKD. And so he knows both the patient perspectives and of the professorial perspectives about kidney disease very well. So this was the flow of his talk, and then from our country, we'll add something what we think is important. So as you all understand that KDOKI has been about 20 years old now, and many of the senior faculty and even the mid-level faculty would realize that in 2000s, once this KDO became a part of our understanding of the chronic kidney disease classification, and we have seen its development. And Professor Levy was very important for initiation, and also at all the meetings an important contribution to this foundation. They also founded the Chronic Kidney Disease Epidemiology Collaboration and CKD Prognosis Consortium, which has brought about a CKD-EPI equation for eGFR. To do a little bit of history, as you all understand that creatinine was first analyzed and came to the clinic when Jaffe's reaction was established by Max Jaffe. And for the glomerular filtration rate, Homer Smith devised many techniques for it, and still today, his method of doing the glomerular filtration rate in clearance is an important technique, though more in the research than in the clinical field. But these are the giants who have contributed to our understanding, and we shall continue to use their methods for our clinic today also. The important development that happened was the MDRD study. The MDRD study was done to establish to know whether low protein diet could delay the progression of kidney disease or not. This trial was a negative trial in the sense that we did not know that the low protein diet is an important method to lower the rate of progression of GFR. However, important thing was that this trial was very well done, and a secondary output of this trial was an important MDRD equation was developed based on the data available from this time. And as we all know that this MDRD equation actually made us convert the creatinine into an eGFR very easily and has been extensively used in the clinical practice. Later for the proteinuria part, as you all understand, Richard Bright made the seminal observation that patients who have albuminous urine have hardened arteries and heart and the kidney and small kidneys. And later on also Herman made important contribution for our understanding of albuminuria as a marker of kidney disease. And also in proteinuria in a very small quantity, which was labeled as microalbuminuria, became an important predictor of the nephropathy, especially initially in the type 1 diabetes, that it is a predictor of nephropathy. But in type 2 diabetes, it also showed that it also predicted that clinical proteinuria would happen and also early mortality in the maturity onset diabetes. So both in type 1 and type 2, it became an important marker of bad events to happen. Not only in patients with diabetes, but also in patients without diabetes, it became an important marker for cardiovascular disease. Next, what happened was that once these two things were established, that both the creatinine and the proteinuria were an important marker of kidney disease, CKD disease. CKD then secondly laid out the classification and grouping of kidney disease. It was important because all of us could talk in the same language as to what do we understand by different grades of kidney disease. Another important contribution of Dr. Levy and his team and people at the CKD was to put up a conceptual model about definition of kidney disease and how does the kidney disease progress. And this cartoon is familiar to all of us, and all of us would have used it in different presentations of us. And it generally established that as you go to the horizontal line, the progressive increase from risk to damage to low GFR and kidney failure and death. And this group, which shows that if there are markers of kidney disease, the GFR is less than 60 ml, then if it is more than for 3 months, establish a chronic kidney disease. Not only it was important that as a disease progresses, but as disease progresses, a lot of complications come in. And as you all understand, that predominant of it is the cardiovascular complications. But apart from cardiovascular complications, there can be anemia and bone disease as the disease progresses. And which recognition is very simpler once we follow this conceptual model. The important other thing that happened was in 2009, there was a London meeting. And in that London meeting, a lot of data was presented. And almost 45 cohorts were studied. And about 1.5 million patient data was analyzed. And all this was when they put into the statistical analysis. One thing became very clear, that as the GFR reduced, there was increase in the all-cause mortality. As the GFR reduced, there was increase in the cardiovascular mortality, increased risk of getting end-stage renal failure. Acute kidney injury was more common in patients who had a reduced GFR, and the progressive kidney disease happened. And as you can see here, that once we did cut off about 60 ml of GFR at all of these time points, it became important that there was a very steep increase in the mortality, cardiovascular disease, and everything. And that's how the concept of a GFR below 60 ml portending a bad prognosis came into understanding. And this is another heat map which was generated after the understanding of the London conference. And as you can all understand, that the categories were initially 5, that is, grading of GFR was 5 grades. But important as to understand is that the biological systems do not follow a step ladder pattern, they follow a continuous pattern. And therefore, when it was seen that in the grade 3, those patients who had a GFR nearing 60, they did much better than those who were on near 30. Therefore, because there was a large difference in them, the group 3 was split into 2, that is 3A and 3B. Similarly, as the proteinuria increased, bad things would continue to happen. And this all red thing tells you that these are very bad prognosis, intermediate prognosis, and reasonably good prognosis over here. So this became a very important concept to analyze and understand how disease would progress. Another important thing was that the further refinement happened when the CKD-EPI equation came. Also cystatin C got incorporated, and especially in certain circumstances, especially in liver disease, this would be an important concept to indicate. And now from MDRD, we have moved to CKD-EPI equation. CKD-EPI equation, especially when the GFR is higher, predicts the conversion from creatinine to GFR is much better compared to MDRD equation. So not only that the chronic kidney disease, that is low GFR and proteinuria, were important marks of progression of kidney disease, but they also became very important for heart disease and cardiovascular disease. It was very well understood in the very beginning. If you can see here, the Scribner's paper, which showed that patients who had were on maintenance dialysis, even young patients, had very accelerated atherosclerosis. And this paper by Mark Sarnak, as you would all recall, numerous times it has been shown that in dialysis population, the risk of getting a cardiovascular disease is much higher. A 30-year-old gentleman may have as much risk as a 70-year-old normal person. And this became very important. And not only in patients on dialysis, but even patients with reduced GFR, there was increased cardiovascular risk. Again, not only that it predicted a poor cardiovascular risk, but both low GFR and albuminuria were predictor of total cardiovascular mortality, stroke, congestive heart failure, peripheral arterial disease, and leg amputation. So it was not only important in the cardiovascular prediction, but also became true for patients with hypertension, diabetes, gender, increasing age, gender, and ethnicity. All of them, if you had low GFR and albuminuria, and it was put into these patients, if they had this, then their prognosis was much worse than compared to if they did not have this. So both low GFR and albuminuria were important predictors of bad outcomes in every type of, or across a large spectrum of diseases. But these papers were not without controversies, because the equation which the CKD-EPI equation, the MDRD equation, many of them were not age adapted, and Professor Glassock and many others felt that a GFR usually reduces as the age advances, and therefore we must have an age adaptation of these equations. But Dr. Levy felt that this is not really necessary, because as the age advances, the GFR reduces and it becomes an important part of the risk factor also. So, but this controversy still continues, and I think at both end of the spectrum, both have very strong points to it, and maybe during discussion we can take it further as to what is relevant to us. It also became important that both proteinuria and low GFR were important clinical endpoints for the clinical trials of kidney disease progression. And as you can see here, that once the GFR falls, to doubling of the GFR is taken as an important outcome in the clinical trials. But one must understand it takes about 50%, 57% of reduction in the kidney function for doubling of creatinine to happen, and which can take a very long period of time. So Professor Levy and others believe that we could use about 40% reduction or 30% reduction. That would mean that 1.5 times of the creatinine rise or 1.3 times the creatinine rise as a reasonable endpoint for the interventions. As such, the number of trials in nephrology are very, very limited because of a long time frame that is required. And probably if we reduce the requirement, maybe more trials will come in and more new therapies will be tried out, and the cost also would reduce. They did enough mathematical modeling and also the data from the registries to show that a 40% rise would be a reasonable guide to know whether the therapy is working or not. Similarly, for the proteinuria, though the US FDA does not approve proteinuria as a surrogate endpoint, but there is a lot of thinking going in the West and also in many other parts that a proteinuria reduction should be an important endpoint and should be considered as a success if a therapy reduces proteinuria. And we can have also discussion on this point later on also. Another important thing about both the proteinuria and the albuminuria is that it led up to a lot of predictive equations. There are numerous equations, but just to allude to some of them, that these equations became important not only to predict the outcome of kidney failure, but they also would often help to predict the cardiovascular outcomes, also help to predict what are other complications which are likely. And this became a very important tool in the clinical practice. And I think time has now come to see if we can incorporate it in clinical practice and guide our patients using these equations also. So in short, in brief, what he thought was that the complete holistic evaluation of a kidney patient should have recognition of increased risk of CKD, that is diabetes, hypertension, testing for CKD, detection of CKD using both albuminuria and eGFR, evaluation for the cause, because that is very important. The CGA concept, that is the not only that you find out the grade, but also find out the cause for kidney disease is very important. So evaluation to implement specific therapies because many therapies can alter the cause and they can do. An assessment of GFR and albuminuria for non-specific therapies. And further, they also feel that detection evaluation management should be tailored to patient risk. Because here where there's a lot of feeling that which patient at 60 ml GFR, a young man of 30 will be treated certainly differently from somebody who is a 70-year-old with 60 ml GFR. And I think this is where it is important that when we utilize these markers, we take into consideration the other comorbidities and the age and the gender and many other factors before suggesting to them what would be their future be. So the points of discussion for adaptation of GFR and albumin in our country is that the most important thing that as in society and as a group that we need to emphasize that the creatinine on which we base everything that we do must be of the most standard quality. Many labs in our country are now using isolation mass spectrometry, but it is not uniform, and we need to promote this and make this as an important consideration for the lab's recognition unless they are IDMS standardized. Another important problem is that most labs measure protein creatinine ratio, not albumin creatinine ratio. And as you have seen in the presentation, that most of the predictive equations and everything have used albumin as the marker. Though KDIGO did give us the conversion factors that if you see over here, if an albumin excretion is less than 30 ml, it corresponds to about less than 150 ml of a protein excretion. The important thing to realize is that whenever there is a low grade of proteinuria, albumin comprises only 30%. In the low grade, that is stage 1, that is less than ACR of 30 milligram per gram, compared to 60% as the stage advances. So at higher stages, the albuminuria and proteinuria may not make a very big difference, but at the lower stages of proteinuria, it would make really a big difference. People have tried and attempted to, and there's a recent paper appeared in JAS, and they tried and attempted to see if we can develop an equation which can convert the albumin creatinine ratio to protein creatinine ratio, so that this equation can be used. And as you can see over here at the lower end of the proteinuria, there is a significant splay, suggesting that it is very difficult to actually correctly predict it, but using some equations, some mathematical modeling, it may be possible to do so. And as you all understand, in our country, doing an albumin at a low level, microalbumin is an ELISA technique, which is very expensive, and the general protein is done by the biounit, which is very less expensive and can be very widely used. So I think we should also formulate some guidelines as to how protein creatinine ratio can be very well incorporated into our understanding of the patient disease and also for epidemiological purposes. So another important discussion, of course, in our country would be that whether the age adaptation of CKD-EPI equation is important, and I'm sure a lot of people will have different thoughts to it. The GFR estimates in our country, especially in the view of the large vegetarian population, because again, this often comes up whether a 60 ml GFR in an elderly lady who's eating a very poor vegetarian diet would really mean that she has got a significant kidney disease or not. And I think, as has been alluded by Professor Levy in his presentation, that we need to take everything into view rather than only single numbers and then put the prediction equation. And maybe in the equations we can use whether there's a vegetarian diet or a non-vegetarian diet to get a better idea about it. So in summary, I would say Dr. Levy presented the journey of incorporating GFR and albuminuria in a clinical practice, and it has now become almost a standard of care, which was not 20 years ago. Though we were using both measures, but in a more standardized method now. Numerous challenges and controversies still remain, as we have discussed in the previous part. And creatinine-based estimation of GFR, albuminuria, and proteinuria still are the best tools for prognostication, clinical trials, and disease management. And we must make them more standardized in our country. Thank you very much, both Professor Gupta and the Emcure team and Dr. Agarwal for inviting me for this talk. I'll stop here and take the mic to Dr. Agarwal.